Hi, good morning. Great pleasure to be here, and thank you for being here. I'm not sure you're going to get a warm glow, but you might have some perspiration anyway. I'm also also on the LMC with our West Sussex LMC group. And the reason that's important is because one of my, it might have been Nav actually, who said that if you don't have a conflict of interest, you're not doing it properly. And I don't see, as GPs and practices that we are who are working in the CCG, that we should call it a conflict of interest. It's actually having the experience and being able to walk and understand the talk we are doing and what we're trying to achieve. So it is really important for general practitioners and people who work in general practice and our CCG colleagues to be able to understand where we are coming from, to be able to make joined up decisions, because we have to be very clear. But I'm going to start with this slide. This came from a really good source recently, but it has not been validated completely, so I'm just going to give it a slight health warning. And you'll see in general practice investment of total NHS spend from 2003, when it was 9%, and we had a high of around 10.4% in 2005-06. The total percentage of spend in general practice has gone down to 8%, and it has been going down. And my general practitioner colleagues would see this in their and we're all working harder. So there are a number of statistics that the number of the patient contacts have gone up by almost a third in the last 5 years. So we're working harder with less resource, but also understanding that 90% of all NHS contacts are in primary care. So in that context, I think we have to work as a CCGs. Now, CCGs for me are community responsive organizations, because that's what we were created to be local, to be clinically led, and patient focused. So that is what our core purpose is. And general practices at their best are community responsive businesses. So we both have a commonality of being community responsive. And sometimes general practices don't see themselves to be community responsive because they're in the community, but they have a contract with whoever they have a contract with, and at the moment it is the NHS England. But if you just think about HMV, who didn't last that long because they weren't responsive to changing times, and I think it's as a GP and as a commissioner, it is imperative on us to be real in our thinking when we are looking ahead to the future. Because sometimes we could live in islands and think that we are safe because we have a contract. And we know that is changing as general practitioners, but as a commissioner, I also see there are a number of changes. So I'll just go through some of the things. So that is the context within which we're working. 90% of all contacts in general practice, 8% of spend, and an increasing workload, and the whole total cake from which we have to do business for providing good health care is reducing. Okay. So, and it's reducing significantly if you look 10 years ahead. If you believe what the NHS, the Nuffield Trust is saying, in the next 10 years, the difference between the needs of the population and the spend would be between 44 to 54 billion. Let's just say it again, 44 to 54 billion pounds different between the needs of the population. So we have to do something different. And yesterday and last week we spent some time in Confed, and the types of words people are talking about is revolution. They're talking about real radical change. They're talking about chaos. And we all feel that. So people are looking at something quite different. And so within all that adversity of chaos, we have a chance of innovation. If things were stable, it's very difficult to innovate. But when there is chaos, you can innovate. When people are looking at radical and revolution, we have a chance to change what we do in general practice. And I would urge all of us to look at this as an opportunity to change rather than the threat that is coming from above. So that mindset. But to be to do something different, we have to have clarity of purpose. Whether you're a CCG, and I'm going to just mix this up with CCG and general practice, and I have a keen interest in both. That unless, so this, Martin Luther King said, I have a dream. And he did not say, I have a plan. And that is very important, because in our hearts we need to know what is the right thing to do, what is the dream we want to do for general practice. Then we can create a plan, because a plan changes, but the dream and the purpose doesn't change. So we're very, very clear about our purpose, why we're here as community responsive businesses or community responsive organizations. So we have to be very clear. The other bit that we have to be clear, whether we are a CCG or a practice, is that our job is to look from protecting good health to easing the passing. And sometimes we're not very clear about protecting good health, because we think only in our contracts it is when sick people come to us we do something. The protecting of good health is not our role, but I think it is very much our role, if it is not now, definitely for the future, and the whole bit in between, and the children and the whole old age. So that is, we share that purpose. We also share the purpose around well-being. And well-being, for us in Crawley, cultural diversity and responding to the needs of the population is really important. So every citizen in Crawley, or in West Sussex, or in England, should have equal opportunity for health. That is what they should have. How they get there will be dependent on your cultural values, where you've been brought up, and all the other things that bring us to that point in time. So it is really important to understand that the journey to well-being may be different, but the outcome should be the same, and that's what we're trying to do, outcome-based commissioning. So the wider determinants of health around risk and poverty, psychosocial risks, behavioral risks, eventually become physiological risks, and that becomes illness. So if we are not looking at poverty, social status, lack of social support, lack of social networks, and poor diet and smoking, we will be picking up the pieces later on which are unsustainable, expensive, and of course bad for us as human beings, as citizens of the country, but also as care providers, because we're picking it up late, and commissioners. So the wider determinants of health are really key. But the people who really got left behind were the vulnerable, the ones with unequal opportunities, and the silent, because they did not enter our premises. They did not enter the conscience of the previous commissioners in as big a way as they should have. But they do create expense, and they create sickness, and we need to be there to help them. That is part of what our role as a CCG and GPs has to be in the future. But what about carers? We all have carer registers in our surgery, but so just to give you an example, the value of them. The value of a care, our total budget in Crawley is £142.4 million. The value of carers that has been done with some kind of rigor is £167 million. If you take away the carers, the whole health service falls. And as you look ahead, the value of carers for older people looking after older people, think about dementia, think about ourselves looking after our older parents who've got chronic illness or dementia. The young child who has to go back and look after their mother with, in this case, with cancer and sometimes with mental disorders or with substance misuse. There are huge amounts of pressures that we have to look at, and we are in the community as GPs and as commissioners. We have to be looking at those, and that is our role for the future. And also the other bit, and if you look at, as a GP, I have great difficulty as stewarding my patients through very, very complex systems, especially when there are so many other providers coming in. We have 6 AQPs in Crawley, and I have no idea which form to fill for which one at the moment. They're all providing really good service, but it is becoming more complex for patients. Some do it on Tuesdays, some do it on Thursdays, and some whenever they can. So, and then we have all the statutory services. And if you are an older person or a person with illness, it is a very complex system. So as a CCG, as a practice, we have to simplify. So we are building up a different type of general practice for the future. And it is linked to our communities, it is linked to our organizations. But as a GP, as a commissioner, I'm looking at a population of 125,000 patients, 50 languages, 13 practices in Crawley. And we know if you take the bus, number 10 bus from Broadfield North to Pound Hill, you'll gain 6 years. Take a right at Three Bridges and you go into Main Bar, you get another year. Of course, not just because you're sitting on a bus, but because that's what happens. And that is a difference between 2 or 3 miles. That's the difference. But although as a commissioner I have to think as populations, but we as practitioners have to think as individuals. And that's Charlie, he's one of, Archie, sorry, he's one of our friend's son. It says, autism is just one of my special qualities. So for Archie and everybody who is special, we have to customize care. So of course, there are national standards, but we have to translate them into local priorities, into customizing it for Archie. And if we don't, if both the parents I know very well, if Archie did not get the support from his GP and social services, both parents would lose their job because he needs that much care. So it is part of the purpose that as a commissioner, as a provider, we need to do something with. But we're all different, not only as GPs, but we have to be in the place. Our next door neighbours are Mid Sussex and Horsham, who are right up there. They're rich, white and wealthy. And in the middle, we have Crawley, which is much more diverse, poor and poorly. And so we have to have different ways of delivering care, but the equity of care should be the same whether you live in Horsham, Mid Sussex, or in Crawley. And your own localities. So we have to understand our populations as GPs, not only as CCGs. If you don't, we are in trouble. Because we know, and this is the graph from the US, that every 10 years the cost of the NHS goes up, or of healthcare goes up. And if you take America, which spends about 17% of its GDP on health, they would be spending 49% of the huge GDP on health by the end of this century. And we have doubled our costs over the years. So we are following that trend. So we have to do something different. So the radical revolution and chaos really comes into its own because we cannot afford to keep going the way we are. And think about the VUCA world. The VUCA world, and I read too many of these management books, I'm sorry, I apologize. The VUCA world is volatile, uncertain, complex, and ambiguous. If you think about the geopolitics, geoeconomics, if you think about all the conflicts we have, it is because they were completely unpredictable. And the complexity of the NHS, we've seen how complex and volatile the NHS is. So in some ways, for us as clinicians and people who work in the system, we need to be able to imagine what it looks like in the next 5 years and then say, if I'm in that situation, what would I do differently? Because that is how we will create the practice we have been thinking about. And Nav came and helped us in Horsham, Mid Sussex and Crawley to think ahead for 5 years. And it was really interesting how quickly our GP colleagues got into that space of being able to imagine the future. And it was actually quite a good future. It was really quite an enlightened future. And all of us who were organizing that were quite surprised by how engaged our GP colleagues, because we have a feeling that our GP colleagues are well rooted in the past and will not move the future. That is not true at all. So what we're trying to optimize together would be the episodic care. Where should the episodic care be done? I was talking to Lloyd's people last night, and they have a view of our episodic care for working age adults being done through using IT. But a lot of episodic care goes to our A&E, and we know that, so I'm not going to... And where does the optimization of complex and long-term care happen? A lot of it happens in the hospitals. 25% of all admissions in our acute hospitals are dementia-related. About 15% are end-of-life related. And 50% of dementia patients who go in will go in walking, talking, and come out in a wheelchair into a nursing home. And so hospitals are a bad place for complex conditions. We have to do something different. And even if it took cut those by 50%, but because that is doable, for us in Crawley, we would save £20 million and be able to invest that in community and primary care services. So we need to be thinking differently and get involved in that part of where we are. And self and supported care, keeping people well, of course. So the patient flows and resources distribution becomes really quite important for us, especially if you work in the community. Are we ready as GPs, as single bodies, to be able to attract commissioning resource if you're taking £20 million by doing something different? I would say we are not, but we have to organize ourselves to be. So the way I think we need to work this through as GPs and as commissioners would be through mutuality and partnerships. There is a mutual benefit for commissioners that the community services and GPs are working together. That social care and GPs are working together, third sector and GPs are working together, the local government and GPs are working together because we look after the same people, but in different ways. And creating partnerships, it doesn't have to be joining organizations, but having mutually agreed partnerships where you share stuff, and that is where we are going to in Crawley, which is calling Crawley PLC. And I'll give you an example. When we're creating something called Crawley a dementia-friendly town. And when we created Dementia Alliance to see how do we normalize the life of people with mild to moderate dementia and give good end of life and good care to severe dementia, we found that the people who were really interested in this was the fire brigade and the police. The police spent thousands and thousands of hours a year looking after little old ladies that you and I would be going out as well because she's got confused. She's walked out the door in a nightie in the middle of winter. And so there is the helicopters are out with lights looking for this lady. So they are very interested in Dementia Alliance. The fire brigade are really interested because they put the gas on, people with dementia forget they put the gas on and walk away and there's a fire. So when we started looking at who's really interested in this complexity, we found there were many partners. Local government, Alzheimer's, of course, are very interested as well. So now we're looking at what do we do with asset-based change. So how do we share our assets? And GPs are in this place, we have huge assets to share. And people are really interested in our assets, but we have not shared them. I think this is an opportunity for us to grow out, to share our assets and grow our practices and be ready for the future. So for us, and as a commissioner, we're looking at creating, because we looked at the wider determinants of health, so supportive communities, supportive networks, and supportive environments are really important. And there's really good evidence from various parts of the system which shows that really this works for all complexities, especially for mental health, especially for dementia and the vulnerable. These are really important bits to keep people well and at home. And we are in a prime position as GPs to understand the complexity because we see them day to day. We know their extended families, we know the networks, we know where they live and how they live because we've been to the houses. What an important place we have in the system to do something important and different. So are all the CCGs in practice the same? Of course we're not. And so the solutions we will find together would be different using innovations which are local and frugal and may not be large scale, but we will be able to find them locally. So we have to have the confidence that to look at our communities and the CCGs within and actively engage in finding the solutions. But at the moment, it feels a bit like this. A lot of the wires which we sell on for many years with our contracts, and this is true for my management colleagues in CCGs, the PCTs and SHAs, which was wherever you flew, you could always come back and land on that wire, and it was okay. And I can, from the conversations that we've been involved with, I think the wire for that GPs is moving as well. So we will get ready for not having a space to come back to. And it feels a bit like this. It's a bit like Jenga. We've been putting stuff on top, add a bit of cough, and because there was money, and now it's falling over. So okay, let's get ready for that bit. So we have, in CCGs, we have a structure, and it is really important that as GPs we get involved with this because we can influence it from the inside. But we have to go there with the idea that we put on take off our hat as a GP provider, but come there as a GP with a knowledge of the community and wants to improve population health. Then we have credibility. Otherwise, people will not take us seriously. Of course, we want to, in the build by share, we want to build in the communities because that's where the money is going to go. And we have to be ready for it. So, and we have to be open and transparent how we got there. But people want to invest in the communities. And I'm saying that openly in our communities, to our MPs, to our people that we want to invest. And nobody's challenged us. So the two bits for us as GPs and as commissioners, do we have the light has gone red, so I need to hurry up, I apologize. The two currencies, and we've concentrated too much on the money side of it and less on the care. And this is, post-Francis, we have to balance those currencies, that we are providing the care and the outcomes within the resources we have. So we don't have a choice, we have to do both. And as a commissioner, I have only that many bags full of money. Once it goes, it goes. So we have to re-engineer the costs. And for us, about 50% of our cash is spent in acute trusts, and then there's a variety of other small things. But it is all given away. So when we look at commissioning I'm not sure why people are giving it such mystique. It's only three things we do. We plan, we buy, and we monitor. So last year we planned for what we're going to buy this year, and we have signed all the contracts and all the money is gone. So now we're going to spend all our time this year monitoring the contracts that they have delivered to the specifications we have, ensuring that patient experience is good and safety is good. That's all. That's the monitoring part of the PDQ, the performance delivery and quality stuff. But now we're concentrating a lot on the planning for next year. And this is a really good time for GPs to step up and say, what can I do for you next year, which will hit all the bits that I was talking about earlier. And they'll be different. So for next year, we have an opportunity, and we know the enhanced services is we're going to go into national contracts. So there are a number of stresses. So do not sit back and relax and say someone will find a solution. It will not come. We have to find it ourselves. And so the development of readiness is there. Are we going to federate? It's a bad F word, but a lot of people are using it, and it's different people. Are we going to become accountable care organizations? Do we take there is evidence that around 50,000 patients you can do this. For us, for 50,000 is worth 60 million pounds. Am I ready as a practice and my practice is ready to take on from prevention to intervention the whole bit, working with other organizations? Maybe our other partners should be community pharmacists as a partner. And so what are the opportunities here? I think we need to think outside, and there are a number of people, and including the Confed, who's looking at this for us. And do we find linear integration with the hospitals, mental health trusts, community trusts, or do we go horizontally with other practices, with the community? We have to make a choice, because it is going to be radical, it's going to be chaos, and it's going to be a revolution, so we need to be ready. And the bits that we're doing, I won't spend too much time around this, is you all doing this, is looking at what happens in hospitals, what can we do proactively, what can we do in self-supported care, and where do we do in care homes. These are areas that you would have all looked at, I'm sure, because this is part of what we're doing. But, let me have a glass. I'm hoping all of us would be doing this by the end of next year. That because we started with things that we can do and then working for the impossible, which is whichever model you choose, because it may seem completely impossible, but I think we need to start with the first step. But we will need courage, leadership, and tenacity. This is Gandhi, and with that body, with those clothes in front of that audience, you need to have courage. There is no way you could do that with that. But he had tenacity, and he led from the front. And it is for us as individual leaders to lead from the front, because our population depends on us to have good sense. We may not want to have a style, physique, and charm of that sort. We might want to be more Gandalf style. How many of you have done the Gangman style in your own, in the privacy of your home with your children? So we've all tried that. It's difficult, isn't it? But this Gandalf style, I think as CCGs, as practices, we need to be loose and flexible and be able to make a fool of ourselves, because that's what we will do. And mistakes are okay. Only 30% of startups actually succeed. But we have to deal with it. We cannot say we're going to walk away because the patient are dependent. They're not going to go away. They will need us to find a solution for their health. We can't walk away. And it, of course, got serious from the 1st of April, because that's our job. But this is what we might want to look like as GPs and as leaders, with style, with charm, and the ability to care. Thank you.
Thank you very much, Amit. Okay, so let's just give Amit a little bit of a break there for a moment while you're undoubtedly reflecting on the questions you want to ask him. Are there any so what in the traditional way, if you could introduce yourself and then ask your question, we might take 2 or 3 in turn, so it gives Amit a chance to cogitate. So, questions, colleagues, things you want to know that you're always afraid to ask before. Now, come on. Okay, we've got a question at the back there, but while that's happening, Amit, I did come to your Crawley CCG development session, and I noted a lot of your GP practices were asking for a bit of headroom for them to do things differently. Can you give us a sense of what you as a CCG did to facilitate that?
Right. The headroom is really important, and the GPs and the practice managers who work in a practice will recognize this. We seem to be working at 110% a time. My wife's a GP, and she picks up her breakfast, puts in a bowl, and is all out of the house by between 7 and 7:30 to do her paperwork before she starts seeing patients. And a lot of GPs do that. If you look at the workload that we're getting, a lot of it is It's because at the first contact, people did not do what they could have done. Whether it's in hospitals, being asked to go and follow up a result for somebody, something else is done, or could you do this? So there's a number of things that come into general practice which are created workloads for us. There's certain things that we don't do. We don't look at best practice to optimize our flows, and that's what we can learn from each other. And we haven't skilled ourselves. We haven't spent enough time on ourselves sometimes. So the bits that we're doing now with our practices, one is working with the acute hospital to say, can you not please send, if you do a test, please make sure that you follow it up. Don't ask me to follow it up because it takes time. And 50% of my administration's receptionist time is taken up with stuff related to the acute hospital. That is not fair because we are not paid to do that. So there's a conversation happening around there. And we're working through the LMC on that. And there are certain things that we're being asked to do for the community, from our community nurses, which is not part of general practice job. We need to find another way to commission it differently or better. But then there's the education and skilling up through the primary care development group that we started that we're looking at. So the primary care development group has suddenly taken on a life which it hasn't had for the last 3 or 4 years. The sessions, the protected sessions have become more important because people are looking at the future, and they're not only looking at clinical solutions and pathways, but they're also looking at organizations. How do we work together? And that's a really important bit about creating headspace. How do we share and reduce our costs when the value coming into general practice is going down? How do we create efficiencies? Because till now we didn't have to do it. We were quite comfortable. We were all well.
Thanks, Amit. Well, let's just take the question from the back of the floor there.
Yes. Good morning, Amit. My name is Krishna. I'm a senior lecturer at the University of Bedfordshire. I just want to know one thing which I think needs to be on your system, or I don't know, maybe I'm too expected. When I see your composition of CCG membership, I didn't see any member from academic team or member from university. Don't you think that having at least one member of academia would have difference in terms of bringing services out or making services more proactive through scholarly activities or sharing these issues with among the students and the staff member?
Okay, thank you. Thanks very much. I think I get a sense, so should there be academic representation of the CCG? We have one more question and I'll ask Amit to respond to both. There's a question just down here.
Hi, Judith Ponslow from Lewisham CCG. Not so much of a question as just a comment really to say we in Lewisham are finding our practices are absolutely overwhelmed with workload as well. So we're very much looking at IT and efficiencies through that mechanism to try and support and drive out some of the manual processes that are in the system.
Thank you very much. Okay, so Amit, academic representation on a CCG board, why isn't there any?
A really good question, Christian. But there are certain things that have been given to us to be on the governing body, and we have we have an ex-medical director, educationalist, who is the secondary care clinician who brings part of that for us. But in the group we have a number of people who have interest in education. But that's not where we stop. The AHSNs, the Allied. Give me the full version of AHSNs.
Academic Health Science Network.
Yeah, those ones. They have a lot of intelligence and they are local to us. And what we're doing with them is looking at where academia working with local population and local businesses, because that is their remit, the AHSN's remit, is to make sure that there's a triangulation between, or there's a connection between all those. So academia is really important, but we are looking at population health. So we bring in the intelligence when we need it, and lots of people are willing to help. But you're absolutely right. We need academics to give us the evidence base when we made the policy.
Okay, thank you very much. Dear all, so sorry that we're having to cut this now. Thank you all so much for listening. I know there are people waiting to get in, and I'm sure you need to get somewhere else. So those who wish to stay, please stay. But thank you all very much for listening, and thank you, Amit, for that wonderful presentation. Thank you very much.